Now please welcome Dr. Thomas Lee, editorial board member of the New England Journal of Medicine, chief medical officer of Press Ganey, and a practicing internist and cardiologist at Brigham and Women's Hospital.
Thanks very much. Welcome to the NEJM Catalyst 2017 meeting on patient engagement. Today we're going to hear some terrific speakers give short talks, but then interact with each other and interact with you, and hopefully create some new knowledge about how we can get the system to work better within itself and to work better with patients so that we can improve their outcomes and do so more efficiently. This meeting is part of an ongoing effort by the NEJM group to try to help the healthcare system move toward higher value more quickly. In previous meetings over the last couple of years, our other themes have included the new marketplace, care redesign, leadership. But at the end of the day, it comes down to getting patients to work together better with us and with themselves so that they can have better outcomes. So this meeting is really where the rubber meets the road. We tried to bring together in NEJM Catalyst people that you might not run into in the course of your daily life and who might not run into each other. What a catalyst is, I think many of you will remember from high school chemistry, is something that puts two things in position with each other so that reactions can take place faster than they might otherwise would. That is very much what we're trying to do today in these three panels. The key theme for the first panel is from two innovators who have been working to try to make the interface between technology and patients better and more reliable. We have two terrific young leaders. One's leading the research on design at a brand new medical school that only opened its doors and took in its very first students less than 1 year ago. The other one's also young. 7 years ago, he was a first-year medical student who was shadowing me for an afternoon of my management roles, and now he's the CEO of a 6-year-old startup which is doing exciting work that you'll be hearing about. It was a terrific afternoon shadowing me, obviously. The second panel is going to focus on understanding the work and potential of social networks and how that's coming into play today. I think we all know that the doctor-patient relationship remains very, very important. But anyone who takes care of patients or anyone who's taking care of parents knows that there are social networks on both sides of that relationship now. Medicine's a team sport. How clinicians work together to take care of patients is really important. And the fact is that how patients interact with the families, how clinicians work with the families surrounding patients is also hugely important. How those families work together is important. We have two folks who have been working on this kind of question on a variety of, from a variety of perspectives. They both blend perspectives. We have a leading primary care physician economist from the University of Pennsylvania, and we have a colleague who also studies interventions for improving chronic disease, but has been doing that both academically, but also in Michigan and in the third world. And her real-world experiences combined with the sort of thinking from behavioral economics will be part of what comes to life in the second panel. The third panel is going to focus on how we move providers from loosely associated social networks into real teams, and so we can make coordinated, compassionate care hardwired. We're going to hear from the chief medical officer of an organization that focuses on the most vulnerable and complex patients in my hometown, Boston, and also the key leader of one of the largest and best integrated delivery systems in the country. That delivery system, Kaiser Permanente, is our host today, and it provides the perfect place for these discussions. KP Southern California is our immediate host here, and you're going to hear from, in our third panel, from one of its leaders who you've already met, Nirav Shah, the Senior VP and COO for Clinical Operations, someone who I think has been one of the most important and effective forces for improvement, both here at KP and before that as New York State Commissioner of Health. The work that he and his colleagues at KP have been doing on high-risk patients, frankly, makes me jealous as an academic, jealous as a clinician. You're in for a real treat today. Now, our speakers won't be giving long talks. They're going to be talking to each other and with the moderators and with you. I hope you'll silence your beepers and phones so you can give them their full attention. At the end of each session, we'll be taking questions from the panelists from our live and our virtual audience. For those of you in the room, you can submit your questions via index cards in your packet, and those of you who are online, you can do it via the web. The full event's being recorded and will be available in a few days. We will be live tweeting this event using the hashtag PatientEngage17. Now, to open our meeting, we'll first hear from the leader of the NEJM Catalyst Patient Engagement theme, Kevin Volpe from the University of Pennsylvania. I think many of us would agree among the very most important and influential behavioral economists in the country and a primary care physician. He's performed so much great research on behavioral change in clinicians and in patients, and he created the vision for this NEJM Catalyst theme, patient engagement, and this meeting today. Ladies and gentlemen, Kevin Volpe.
The U.S. ranks first in health spending and 26th in life expectancy. I think we would all agree this is not a motto we'd be proud of, and we should be able to do better than this. So let's think about what we might do about that in the context of heart attacks, the #1 killer of Americans. Imagine you wanted to prevent as many heart attacks as possible in the US over the next 5 years. Furthermore, imagine you control all research spending in the United States. Would you put your budget into A, developing more effective treatments, B, developing a vaccine, or C, increasing adherence to existing therapies? Your answer to that question might depend on your answer to the following question. What percentage of patients take all their cardiovascular medications in the year following a heart attack? I've found in asking this question to various audiences that very few people raise their hands to option A, 85 to 100%. People realize it's very difficult to achieve full adherence to a medication every day, particularly if your condition's asymptomatic. A few hands go up to option B, 70 to 84%. A lot more hands go up for 50 to 69%. And depending on the audience, depending how cynical they are, depending how grounded they are in the clinical literature, either a small number or a lot of hands will go up for 40 to 49% or below 40%. Now let me pause for a moment here and highlight for you that there's perhaps no other area in medicine where there's so many carefully done clinical trials that really highlight the efficacy of these therapies in both preventing heart attacks and saving lives. Yet despite that, in a number of studies, sadly, the answer is below 40%, and this is true even in insured populations. So let's come back to this question of where the US ranks compared to other countries with which we're commonly compared on life expectancy and health spending. It's interesting when you look at this graph, you can see that in the 1970s, we all started at about the same place. Over time, health spending has risen much faster in the US than in other countries, but now in terms of life expectancy, we see we rank far below countries in Europe, Asia, Australia, Israel, New Zealand. So why might this be? Clearly, it's not because we don't have access to the new therapies, the new devices that all these other countries have. Many of them are actually invented in the US. But arguably, we have much bigger challenges in terms of social and behavioral determinants in health. And we have to figure out how do we get more health for all the money we're spending on health care. Let's think further about reducing the risk of heart attacks. Experts have estimated that with perfect adherence, we might be able to reduce heart attack risk by as much as 62 to 88%. It's very unlikely we could ever attain perfect adherence, but clearly it seems like we should be able to do better than 40%. Let's think about how we might do this if we could do better early detection, prediction of disease, more aggressive prophylactic treatment so that these heart attacks never happen in the first place. Here's one strategy for thinking about reducing heart attack risk. We could do much better in terms of predictive analytics. I'll talk more about that in a moment. We can use design principles. Stacy and Sean are going to talk more about that in this session, about how we think about putting the patient in the middle of the healthcare system as opposed to the provider. We could do much better in leveraging people's social networks, really tapping into the reservoir of goodwill and support that a lot of people have in terms of friends and family. We could do much better in terms of testing ideas on a continuous basis and not accepting mediocrity in our scaled-up solutions. And then furthermore, we need to think about how do we design a new service delivery model which really is focused less on treating acute disease and in preventing disease in the first place. So let's think about factors that put people at elevated risk. Obviously, what people eat, how much they smoke, their blood pressure, their cholesterol. We can pull all that fairly readily from clinical data now and come up with reasonable predictions for who's at elevated risk of having a heart attack. But we can actually do much better than that now, and we're not consistently doing that. We can use natural language processing and really look through electronic medical records and assess people's social determinants of health. We can look at what's revealed in terms of wireless devices and wearables, in terms of people's behavior, revealed on social media, in terms of people's interests and concerns. And in essence, we can come up with much better predictive models than we typically do today, where we can much more systematically look at who's at elevated risk in the future and think more aggressively about how do we keep their risk as low as possible. Next, let's think about rapid cycle innovation of pilot ideas. A lot of organizations will prematurely scale solutions which are either moderately effective or modestly effective. But think about the challenge at hand. We have average adherence rates for very high-risk patients of 40%. Clearly, we don't want to scale up solutions that achieve only modest improvements in that. We need to think about how do we leverage what's been learned from the technology industry. How do we look at A/B testing, doing this much more systematically, where we have promising ideas and we're constantly testing them against each other, constantly trying to improve. We may not achieve a breakthrough instantaneously, but that's going to be the best path forward for making incremental progress that continues. Next, we can think about leveraging social networks. Lots of people have a family member or friends who would be very happy and, in fact, eager to help them improve their health if we only let them. And there are a lot of privacy rules which sometimes make this difficult. But with patients' approval, there's lots of ways we could think about pulling the patient's social circle in ways that could help reinforce their behavior, perhaps in some cases with the use of technology. That brings me to my next point, which is really thinking about new service delivery models focused on prevention. Think about the typical way we manage disease today. It's really based on the fee-for-service financing system. We focus on treating acute events after they happen, and we also, for chronic disease, have patients come and see a doctor every month, every 3 months, perhaps every 12 months. At those visits, the patient is asked to recall everything they can about what happened since they last saw their doctor. How well people can do this obviously varies, and it's also very difficult for people to recall the details of what happened 4 weeks ago, 8 weeks ago, 11 months ago. Imagine an alternative world in which patients at elevated risk had wireless devices and wearables to monitor their smoking status, their medication adherence, their physical activity. These data could be seamlessly uploaded into secure settings. We could have automated algorithms that give patients or their social supporters feedback on how they're doing. And then through an exception handling process, we could have physician extenders reach out to patients who are not doing so well, help them figure out how to better navigate the system, help them figure out how to improve their medication adherence. And you can see how that would create both a more effective and more efficient way of allocating healthcare personnel. Finally, it's very important to think about design, and Sean and Stacy are going to talk a lot more about this. And I think there are a few important principles to think about. One is really having the patient in the middle. We tend to set things up so it's at the convenience of the physician as opposed to the convenience of the patient. Think about the typical care delivery system where a patient will come in to see a physician and wait. Sometimes they wait 10 minutes, sometimes they wait an hour, sometimes they wait 2 hours. Intermountain in southern Utah is building a new clinic, which I think has a very interesting concept. There's no waiting rooms at all. You arrive, and you're just brought to where you're going to be seen. And as I was talking about with these new service delivery models with wireless devices and wearables, maybe in many cases the patient doesn't even need to be seen. If we're monitoring their blood pressure, their cholesterol, their medication adherence on a regular basis, we can provide a lot of support to people remotely from the convenience of their own homes. They don't even have to make the trip in to be seen, but not without any sacrifice in the quality of the support they receive. Each year, about 735,000 Americans have a heart attack. In our current system, we wait until patients have a heart attack and go over the proverbial waterfall. And then we stop at nothing to try to rescue them. And that's appropriate that we would try to do that. But imagine if we could divert the flow of water and really prevent patients from having those heart attacks in the first place. That would obviously be much better for those patients. It would also obviously be much better for our system in terms of trying to improve our life expectancy. As you'll hear more during this meeting, there are lots of promising approaches to designing a system that focuses on keeping people healthy, that leverage social networks in support of patients, and that provide whole-person care and addresses social determinants and behavioral challenges to preventing disease. Thank you.